Hi and welcome back to another video of Medic Notes. This video is on BRASH syndrome. The BRASH acronym is used to describe a syndrome where the synergistic effects of AV nodal blockers and renal impairment lead to severe bradycardia and hyperkalemia. It is named after the signs associated with this condition: bradycardia, renal failure, AV nodal blockade, shock, hyperkalemia. The most common precipitants are hypovolemia and medications promoting hyperkalemia or renal injury. One of the most common causes is hypovolemia, resulting from dehydration and a subsequent pre-renal acute kidney injury. This is often precipitated by a gastrointestinal illness such as gastroenteritis or a decreased oral intake. Other common triggers include up-titration of medications that alter the cardiac output or renal perfusion, as well as the addition of nephrotoxic agents or potassium-sparing diuretics. For its pathophysiology, it involves the synergistic effect of AV nodal blockade and hyperkalemia resulting in severe bradycardia. The resulting reduction in cardiac output, in turn, leads to poor renal perfusion, therefore worsening the acute kidney injury as well as the degree of hyperkalemia. It is well documented that severe hyperkalemia alone can cause bradycardia. However, due to this synergistic effect, profound bradycardia can occur even in the setting of mild hyperkalemia. This is a diagram showing the mechanism. AV nodal blockers causing renal failure, then cause hyperkalemia, bradycardia, poor renal refusion, and hence again worsening the AKI. Clinical presentations in these patients vary widely as they can range from asymptomatic bradycardia to cardiogenic shock requiring vasopressors and hemodialysis. Despite these variations, all patients will present with profound bradycardia. As this syndrome is often precipitated by decreased renal perfusion, history often includes recent gastrointestinal illness, dehydration, recent medication changes, or other history components identified as risk factors for acute kidney injury. For investigation. ECG. In isolated hyperkalemia, as the serum potassium levels elevate, the T waves begin to peak with PR interval prolongation followed by QRS widening and subsequent bradycardia. However, these morphologies are commonly absent in BRASH syndrome patients. For treatment, aim to treat hyperkalemia, bradycardia, hypovolemia, and renal hypoperfusion. Calcium. Hypocalcemia increases the cardiotoxic effects of hyperkalemia. Therefore, prompt intravenous administration of either calcium chloride or calcium gluconate is warranted. Next, adrenaline. If bradycardia persists, epinephrine can be used, which will increase the heart rate and increase the systemic vascular resistance and shift potassium back into the cells. Crystalloid resuscitation with isotonic sodium bicarbonate. Enhance potassium excretion by diuresis with potassium-wasting diuretics such as furosemide or, if anuric, then dialysis. For the prognosis, most cases of mild BRASH syndrome respond well to basic medical interventions, but more invasive therapies such as hemodialysis or transvenous pacing may be required. Prompt recognition of this syndrome improves prognosis and decreases the likelihood of requiring these more invasive measures. The severity of acute kidney injury and hyperkalemia are the main compounding factors that affect prognosis. Complications of this syndrome can range from renal failure resulting in the initiation of hemodialysis, to the development of cardiogenic shock requiring vasopressor initiation or transvenous pacing. If left untreated, worsening hyperkalemia will result in cardiac arrest. That's all for this video. Thank you.